Good afternoon and welcome to another edition of Evergreen Talks. The second Thursday of every month at 4 o'clock is Evergreen Talks right here on both Facebook and YouTube for Evergreen Family Medicine. And in Evergreen Talks, the Evergreen physicians, providers, and specialists present topics that matter to you. And you can see more information about Evergreen Family Medicine online at evergreenfamilymedicine.com. On Facebook, YouTube, Instagram, and Twitter as well to see when the next Evergreen Talk is coming and who the guest will be, or whom the guest will be if you want to get into serious grammar discussions. But today, Evergreen Talks likes to welcome Scott Goebel. He is a PA at Evergreen Family Medicine. How are you today?
I'm well, Brian. Thank you.
Terrific. Well, we look forward to your presentation today on bringing POC Ultrasound to primary care. I'll give you the floor in just 1 second. One other housekeeping thing is that we are live right now on both Facebook and YouTube and would love to have your questions, and we will pick and choose a little bit. We'll vet the questions, but if you ask a question of Scott Goebel based on his presentation and it leads to another question, we'll go through the Q&A at the end of the presentation. But until then, Scott, please begin.
Thanks. Thank you again, Brian. So the topic today is bringing point-of-care ultrasound or POCUS to primary care. My educational background is a master's degree in physician assistant studies at OHSU. During that time, I did have some clinical exposure to point-of-care ultrasound in clinical training, as well as during an inpatient cardiology rotation, although it was limited. Dr. Tim approached me approximately a year ago. Well, he approached many of us, and he asked if we want to really champion this. And so I've been spending the last year working on finding resources, educating myself, and doing a lot of practice on patients, trying to hone this skill. Next slide. The objectives today, this is really focused towards the patient. I don't want to make this overly clinical. I want to help you understand what is ultrasound and how does it work? How does it work to produce a picture? Why ultrasound in primary care? A lot of people are familiar with ultrasound in emergency medicine, ultrasound in primary imaging studies, but why integrate this into primary care? Well, why now? And what are the applications? And I wanted to do some case reviews just so you can understand these applications and make it a little bit more real. Next slide. Ultrasound is basically, well, it's a frequency, a sound wave above what humans can hear. Our typical sound ranges that we can audibly hear is between 20 and 20,000 hertz. Hertz just is a cycle a second. And you can see on this picture that there are some animals that can hear below what we can hear, like elephants can hear, I think, down to 5 hertz. Bats and dolphins can hear up to 160,000 hertz. And so there's this broad spectrum of sound waves that we're exposed to but never hear. Ultrasound image utilizes somewhere in the 1 to 20 million hertz or million cycles a second. Next slide. This is just a visual representation so you can kind of understand how ultrasound works. In the top, you see a speaker. Everybody's seen a speaker. We listen to speakers. What a speaker is basically you have a amplification and the signal that goes to a crossover, that goes to a frequency that drives a speaker in and out. And with the speaker, you see it move. If you ever seen the big woofers move, and they create compression waves, and it's those compression waves and the frequency of those waves that we hear and our brain interprets into sound. The ultrasound transducers actually do the same thing. You have it's just much faster. You have an electrical signal that comes into a transducer, and there's something in the tip called a physioelectric crystal, which will produce compression or vibration in mechanical compression of molecules producing high frequency sound waves. Next slide. This transducer that produces these high frequency sound waves is actually primarily a receiver. What happens is the transducer will pulse high frequency sound waves that go and bounce off internal tissues, and then it listens. It pulses and it listens, it pulses and it listens. And as a transducer, it pulses. As a receiver, it listens. So it transmits mechanical energy, electrical energy into mechanical energy into your tissues. That comes back. It is then transitioned back from mechanical to electrical energy, and it's interpreted by the computer and develops an image. Next slide, please. So what is point-of-care ultrasound or POCUS? POCUS is a limited ultrasound imaging protocol. It's performed at the bedside by your provider to enhance the physical exam, assess many conditions, which help guide further workup and or treatment, and sometimes lead directly to a diagnosis. Next slide. So why ultrasound in primary care? Tools aren't new. You see on TV or you see your doctor that the stethoscope. It's a really classic picture of a medical provider or nurse provider. That's a tool that we use to better evaluate the heart, to evaluate arterial systems, and the abdominal system. It just gives us a better insight into what is going on. We use a multitude of other tools, visual scopes, hammers, tuning forks, and this is all utilized to help us synthesize a differential diagnosis. Coming to a diagnosis is not easy, and tools help us to get a better idea of what's going on. Point-of-care ultrasound or POCUS is simply another tool. Next slide, please. This really allows for a more accurate physical exam, improving diagnostic efficiency and accuracy. This has actually been studied. It's been studied in emergency medicine, showing that it's actually even better than a chest x-ray. A point-of-care ultrasound can be even better than chest x-ray in diagnosing many lung conditions, such as fluid around the lungs, fluid within the lungs, or infection. They've looked at how accurate is a generalist with this device, and even something as specific as a cardiac function or how efficient your heart is pumping can be accurately assessed by a generalist at the bedside. Next slide. Point-of-care ultrasound also provides a rapid answer. So if you think about when you go in to see your provider, you have a complaint, they listen to you, they do an exam, and decide, hey, we need more data. I'm going to order this ultrasound. They order this, you go home, you wait, you get scheduled. Your schedule gets interrupted again. You have to go into an imaging facility on another day, later the same day. You wait for a radiologist to interpret this image. Then you wait for your provider to give you feedback and what are the next steps. In contrast to this, a point-of-care ultrasound exam is completed at the bedside and takes minutes to perform. They've timed this, and it can be very quick. A limited cardiac ultrasound can be completed in 2 minutes. DVT, AAA screenings, that's an aneurysm screening or a blood clot in your leg screening. can be completed at the bedside in less than 4 minutes. Next slide. Cost savings is another reason for point-of-care ultrasound. Studies have shown that a dramatic reduction in costs with point-of-care ultrasound, avoiding imaging, more advanced imaging like CTs and MRIs. Limited ultrasound is also more affordable than a formal ultrasound screen. It's a limited code. It's a more focused exam, and therefore doesn't cost as much. You also have the reduction of downstream effects. You think about radiation within CTs, in the potential adverse effects long term with that. It's ultimately would result in cost savings. Next slide. So why now? Well, this has been actually going on for a long time. There's been a lot of institutions, providers, pushing for this for a long time. I've just been into this for the last year now, but really there's several factors that have kind of come along that have allowed this to be accessible now. Portability and cost is a major factor. Previously, ultrasounds machines cost several, up to $100,000. Now you can get a handheld device for a couple $1,000s. The original, machines, they were very complicated. They have their own language. You have to learn the knobology of the machine to be able to even use the machine. And so a generalist might look at an ultrasound machine and just say, I'm just going to order it. I'm not going to try this myself. But the new devices and the new technology, it adjusts a lot of the settings for you. You can click different applications. It'll automatically adjust, and you can start imaging. The other thing is time efficiency. You have a 20-minute appointment. Your provider's looking at a multitude of things. You may have some acute concerns, and then it comes to an exam, and there's simply just not enough time to apply ultrasound. But now with these portable machines, with validated studies on the accuracy of limited exams, your provider can do a quick ultrasound and get the data they're looking for. The other thing is online training. There's so much online now for education that really brings the training aspect of this to your fingertips. There's online, there's institutions, the AIUM or American Institute of Ultrasound and Medicine. They produce guidelines on proficiencies. They produce guidelines on documentation. They provide lectures, CME. There's independent organizations like Point of Care Ultrasound 101, Core Ultrasound, where you can subscribe and you can actually get continuing education and you can learn about this. And they're well done. And they also integrate into some of the more advanced, newer technology, the smaller handheld devices. Next slide. So what are the applications? How could this, or how is this utilized could it be utilized for you with your primary doctor? Well, really, I mean, I'm finding more and more applications. Limited cardiac exams is a big one I utilize. Carotid artery evaluations, that's the blood flow in your neck. Looking at the lungs, looking at the interstitial space, looking surrounding the lungs, looking at the abdomen, looking at your gallbladder. Do you have an infection in your gallbladder? Is there a stone in there? Do I have a blood clot in my leg? Is this an abscess? What is this growth? I think I have a kidney stone. My provider noticed I had a thyroid nodule. Do I actually have a nodule? Those are kind of hard to feel. I think I stepped on something. Is there something in my foot? I think I tore my rotator cuff. What do you think? And so there's a lot of applications for common complaints that this can be utilized in clinic at the bedside. Next slide, please. So I wanted to go through some cases that I've come across. I utilize ultrasound in my clinic every day. There's a lot of cases to choose from. I just thought these were kind of interesting because they really did change the course of where things were. They provided some reassurance. So I saw this patient several months ago now in a hospital follow-up. She was unfortunately had a prolonged downtime at home after a fall. She subsequently diagnosed with an infection in the hospital. She was hospitalized due to this weakness, discharged with antibiotics. She came in a wheelchair, and she said, my big problem is my leg. My leg hurts so bad. I also feel sick. I have chills. And the leg was swollen, it was red, it was tender in the calf. And I was thinking, well, she's on IV antibiotics. This kind of looks like cellulitis. This is an antibiotic that would cover this. But I decided, let's take a closer look. And I got the ultrasound out and I put it to her leg, and sure enough, there was a very large, and we directed Minden back for a surgical consult. Fortunately, she was able to have this drained, which it needed drained. She had a wound vac placement, and I saw her back several weeks later, and she was doing rather well. Next slide. So this is just some picture that you can see that you can actually see the difference in cellulitis. You see this cobblestoning edema, and in the abscess you see actually these large fluid collections of kind of these darker areas. In point of care ultrasound, they looked at this, and it changes management in quite a bit of cases in trying to determine, hey, is this just cellulitis, or is there any abscess? Is there anything that needs to be drained here? Next slide. This is actually very common patient. This was kind of a curious, I think a good case, because there was an issue of communication. I had a patient of mine that has advanced dementia. She was hospitalized, heart failure. She was put on medications to get off excessive fluid because her heart wasn't moving fluid forward well, and it was building up. And I saw her in clinic. Hey, do you have any symptoms? Well, I feel fine. Her vital signs look good. I looked at her weight, vital signs, blood pressure, heart rate, looked at her body weight, looked to see if she had swelling. Everything looked fine. And so I wonder, are we doing enough with her water management? So I got my ultrasound out and I looked at her lungs, and sure enough, she had fluid around her lungs. She had fluid within her lungs. She had fluid dilating her vasculature, and if I would have just got off symptoms, I could have said, hey, I think everything's going okay. We'll see you at follow-up. But ultrasound led to a direct management change, and I increased her water management, and I'm following that up closely. Next slide. This is just a visual representation of what you might go through if you're going to have what's called a clue exam. This is an exam that was developed by a cardiologist or a team, Bruce Kimura out of Scripps in I think San Diego, and they do this limited ultrasound on pretty much all their patients. It's kind of something that they do in patients in the hospital to determine, hey, what's their pressure like? What's happening in their heart? Are we doing the right things? Are the medications working? And this is what I was talking about earlier. This is a exam that can be quickly done in clinic in less than 2 minutes, and it can directly impact your medication management. Next slide. Next case, it was kind of an interesting case. I was seeing my panel, and another provider came over to me and said, "Hey, I have a lady here that is very concerned. She has a DVT. She actually was in the ER yesterday, which is a blood clot again in the leg. She was seen in the ER, and they did a study. They said, no, you don't have a DT. Go see your primary. She's here, and she is convinced she has a blood clot in her leg. We scan her. And I went in there. I was able to scan all her venous structures while she was looking at the screen. I was showing her how everything was collapsible, how her veins, there was no evidence of a clot in these veins. And she left, reassured that she could actually sit there with me, with a provider, and visualize this as we're going along. I don't know if she got that in the ER. Next slide. This is just just showing that a lot of times we get overwhelmed when you think of, we're going to do a whole, ultrasound for DVT. There's these long protocols. I've got to, do the common femoral vein, and look at the greater saphenous, and all these different veins. I got to go down. But actually, a very limited protocol, 2 or 3 point limited scans are just as good, almost as good for detecting DVT as whole leg ultrasounds. And this is just kind of a push to some of my colleagues that, again, this can be done very, very quickly in office. And that's actually the last slide.
Well, thank you, Scott. So I'm just sitting here thinking about a recent experience that I've had and I'll take the screen down. There we go. So I had a family member in intensive care and suffering from COPD and the potential for pneumonia and the buildup of fluid while he was on a BiPAP. And all of it seemed like moving him was going to be difficult. Trying to see for sure it took a CT scan, I believe, and an MRI of his chest and of his head to see all of the things. Now, some of that probably is necessary, but I was thinking maybe towards the end when and he passed away, by the way, but towards the end when they wanted to know and check up and time was of the essence and moving him was difficult. Is that another scenario where an ultrasound like this potentially could save time and comfort of patient and these kinds of things?
Yeah, I absolutely think so. As far as what is the status of what we're doing, it would be very easy for during rounds, for the internist, hospitalist, be able to come in with the ultrasound, and I think that some of them do, and look at volume status, and look for new infiltrates, fusions in the lungs. Are we ventilating this patient well? Are we diuresing well? That would be a great application, Brian. It provides a lot of real-time information. You don't have to wait for. Sometimes advanced studies are needed and necessary, and sometimes you need a radiologist, someone that has spent years of training. You need their help to look at the full picture. But in a longitudinal follow-up, I think that would be a great application in inpatient care.
A question that came from a viewer on Facebook is, what are the actual limitations then? What is basically keeping this technology from being deployed more often?
I think some of the limitations are just the time, the hesitancy, I suppose, as it was one of the limitations with providers, that this hasn't been integrated into, it was never integrated into their education or their residency. But you're going to see less and less of that. The AAFP the American Academy of Family Physicians. They've made broad recommendations to have point-of-care ultrasound included in formal medical education. The AIUM as well. And I think what you're going to see is more and more new providers feeling very comfortable with this technology, and I think in a way, with the once other providers start seeing how quickly you can actually pick this up, the hesitancy will kind of go away. Most of this is just like, hey, I'm a generalist. I'm not a radiologist, but there are a lot of nice clinical signs that you can look for in limited ultrasound that are not hard to interpret.
It's as you talk about innovation and technology and adopting technology in medicine, I just wonder what the future holds for technologies like this. And I imagine the Star Trek, thing where they just take and they go just right over your head and it tells you everything.
Yeah.
How long? Now I'm not going to actually ask you a question about that at all, but the technology is incredible, right? And it moves moving along that way. It seems
it is, and well, and even within these programs, I mean, you used to, when you did a scan for a bladder, you used to have to run the dimensions through a calculation to figure out volume. Well, it does it for you now, and and I think we're not too far out from this, live scans, cardiac scans, where you're seeing, of it maybe actually being able to calculate things like ejection fraction without you having to put in dimensions and Doppler and everything like that. So, yeah, I think there's going to be more innovation with it. Yeah.
Well, Scott Goebel is a PA at Evergreen Family Medicine, and thank you for your report on point of care ultrasound. Very cool.
Thank you so much, Brian. And thank you for everybody who joined today. Have a wonderful day.
All right. You can join us on the second Thursday of every month at 4:00 for Evergreen Talks, our monthly Facebook and YouTube live event where physicians and providers and specialists from Evergreen present topics that matter to you. And you can see more video and more information online at evergreenfamilymedicine.com. And you can follow Evergreen on Facebook, YouTube, Instagram, and Twitter. All right, Scott. Take care. We'll talk to you again another time.
You too. Thank you so much.